Good morning, all. Respected Dr. Professor Vinu Singh, Director, Professor Jayajendra Dean Academics, Dr. Rohit Gupta sir, and one of all present here. I am welcoming you for the CPC discussion today. I am Dr. Ramesh Prasad, Senior Resident from ENT Department. I am also welcoming Dr. Professor Manu Malathur sir, Dr. Prashant Dungla sir, Department of Pathology, Dr. Arvind Kumar sir, and Dr. Udit Solan sir for the CPC meeting. First, I am welcoming Dr. Vetri, Junior Resident, to start the CPC.
Good morning, everyone. Today, let's get it from the discussion. I am presenting a 22 years old male who presented with complaints of intermittent mucopurulent discharge for the past 1 year and bilateral nasal blockage for the past 1 year with complaints of decreased smelling sensation for the past 6 months. There was no history of visual disturbances, watering of eyes, excessive sneezing, fever, evening rise of temperature, night sweats, falling of crust from nose, cough and headache. He has a past history of generalized tonic-clonic seizures 8 months back. He was started on tablet levetiracetam for the seizure episodes. His last episode was on April. He has a history of incision and drainage from left forehead swelling 1 year back. He gives a history of surgery, but there were no records available. And he is not a known case of any allergic disorder. Coming to the examination, general face examination, we noted a scar which is healthy in the left side of the forehead, and this is the scar in the left side of the forehead. Yes. And he's having a firm to hard, non-tender, basilated swelling over the left side of the frontal region. And he has a diffuse swelling in the left supraorbital region. Coming to the external nose examination, the external nose is normal in appearance. There were no deformity, no tenderness, and the vestibular examination is normal. In basal view, there is no caudal septal deviation. The nasal cavity is checked for patency. Both nasal cavity is obstructed, and there were no paranasal sinus tenderness. Coming to the endoscopic examination of the nasal cavity, we found a mildly deviated nasal septum towards left, and it revealed a pale polypoid mass in both nasal cavities, which is insensitive to touch and doesn't bleed on touch. The nasal obstruction is not relieved by Cortell's maneuver. So the obstruction is beyond the anterior part of the nasal cavity. No, Cortell's maneuver is we will retract the lateral skin cheek to relieve the obstruction at the level of internal nasal valve. Coming to the ocular examination, we noted a diffuse swelling in the left supraorbital region with mild proptosis of left eye. An ophthalmologic examination has been done, which revealed normal findings. There is visual acuity is normal. Fundal examination also revealed no papilledema. Then general systemic examination and neck examination revealed no significant findings. So this is the case summary. He is a 22-year-old male with complaints of nasal blockage and intermittent nasal discharge for the past 1 year and decreased smelling perception for 6 months with no history of allergy and with history of prior surgery with a swelling in left forehead and supraorbital region with mild proptosis with endoscopic findings of multiple pale polyps obstructing bilateral nasal cavities. So,
With this history, any differential diagnosis from the audience?
From the history and clinical examination, we see bilateral polyposis. The most probable diagnosis will be the chronic rhinosinusitis. It might be inflammatory or infective etiology. The most common scenario in the day-to-day clinical examinations, we reveal that it is a chronic rhinosinusitis with bilateral nasal polyposis. And other TDs might be granulomatous disease.
Yes, ma'am. According to the recent e-post variant also today, with this chronic rhinosinusitis, if it is patient presenting with nasal obstruction and nasal discharge, will be a chronic rhinosinusitis. Dr. will take this question.
yeah, now we have a panel of differential diagnosis. It might be chronic rhinosinusitis with nasal polyposis with orbital complications, or left chronic invasive or granulomatous fungal rhinosinusitis. It can be allergic fungal rhinosinusitis, or it can be chronic rhinosinusitis with bony complications, or it might be a left sinonasal tumor.
Possibility, because we have a swelling which was there and which was operated, which was probably a sebaceous cyst, and now there is a little bit of proptosis also of the same side of
Yes.
eye. So just thinking that in addition to what we have seen, there is definitely polyposis which is present, which may be as a result of chronic rhinosinusitis or de novo. There is a possibility of some space occupying lesion, which may be supraorbital or retroorbital, not retro, supraorbital, which can have some communication if at that time, because many times these cysts may communicate with the nasal cavity, and that may have produced a tract or something from which the discharge is coming. So one would radiologically like to rule out what is happening in that area also.
In one CPC we have discussed about AIIMS disease, where again the same, this has not progressed up to that level. There is massive proptosis in the case. So can there be a differential of AIIMS here?
No, I don't think, Dr. because primary manifestations of AIIMS the primary manifestations of AIIMS in that case presented with orbital proptosis only. So there were no nasal findings, since he has mentioned that nasal findings first, and there was a pale polypoidal mass in the nasal cavity causing bilateral nasal obstruction. We first have to think about the nasal and paranasal sinus pathology. So I don't think we should have thought about that first. And with that, we can consider the orbital complications of sinonasal disease as the differential diagnosis first, then the AIIMS disease.
Now we will see the favoring points and contradicting points according to our history. With it might be chronic rhinosinusitis with nasal polyposis with orbital complications. The points favoring are being a young individual with complaints classical of chronic rhinosinusitis, the nasal discharge blockage and decreased smell perception, with mild proptosis and endoscopic finding revealing polypoid masses. The points against are there is no ocular involvement, there is no visual disturbance in patient. So for granulomatous fungal sinusitis, it is contradicting because usually the fungal rhinosinusitis will be unilateral, but we should not exclude only because it is bilateral. And allergic fungal rhinosinusitis, it is not, because there is no response to oral corticosteroids and there is no proven type 1 hypersensitivity in this case. So with bony complications, it is actually favoring. There is a basilated swelling in the forehead, and with history of seizures, we will expect an intracranial extension. So it might be a sinonasal tumor. Now I would like to invite Dr. Kanak to discuss the preoperative radiology.
Good morning, respected teachers. We will discuss preoperative CMRI brain and PN scan for this patient. On axial T2 images, we are appreciating diffuse polypoid mucosal thickening involving the maxillary sinuses as well as thickening involving both the nasal cavities. There is bowing of the walls of the nasal cavity and the septum. Ethmoidal air cells are also filled with the mucosal contents. And bowing is seen along the medial walls of bilateral orbits. Frontal sinuses are also filled. So now coming to the most aggressive part. So what we have seen is the background sinonasal polypoidal disease. In the frontal sinus on the left side, there is T2 hypointense lesion which is along the posterior wall, and it is extending into the intracranial space through the defect in the posterior wall of the frontal sinus. A large component is seen in the left frontal region. It is T2 peripherally T2 hypointense and centrally T2 hyperintense, and interface with the brain parenchyma is ill-defined at multiple places. So this is the intracranial lesion, which is T2 hypointense, and it is showing extensive white matter edema surrounding with significant midline shift and mass effect in form of compression of the left frontal horn and left lateral ventricle. And midline shift of 23 mm is seen towards the right side. So we have two pathologies. There is a background ongoing chronic indolent sinonasal polyposis, and there is one aggressive appearing lesion in the frontal sinus which has got intracranial extension. And along the anterior wall of frontal sinus, it is extending into the soft tissue planes in the subcutaneous planes. This would be the reason of ocellated swelling in the forehead of the patient. In the sagittal image, we can appreciate that the lesion is showing very ill-defined interface with likely invasion of the cortex in the frontal lobe. There is no CSF space at most of the places. Here we can see some interface between the lesion and the brain cortex, but at most of the places the interface is very ill-defined. So based on the imaging findings, we had given differential of sinonasal polyposis with an aggressive pathology. And as a differential of aggressive pathology, we thought of it being a atypical complicated sinusitis or aggressive sinonasal malignancy. On the diffusion weighted images, the lesion shows peripheral restricted diffusion which is hypointense on T2, so that denotes increased cellularity. On post-contrast scan, the rest of the thickened mucosa of paranasal spaces shows normal retained enhancement in the maxillary sinuses, ethmoidal sinuses, and the patient has proptosis on both sides, which could be explained due to bowing of the medial walls of orbits and resultant mass effect on the intraorbital contents. And the frontal sinus lesion shows extensive enhancement. It is more than which is compared to the rest of the sinuses, and intracranial component also shows fluid enhancement. This is the multiple defects in the frontal sinus walls in the posterior side with extension of the lesion into intracranial space, and anterior extension with enhancement in the subcutaneous planes. Now coming to the preoperative CT. So we have paranasal sinuses and nasal cavity filled with mucoid contents with bowing and remodeling of the sinus walls, which suggests long-standing polyposis or long-standing benign disease. Bowing of the lamina papyracea. And in the frontal region, there is sclerosis of the cortex with multiple areas of breach in anterior and posterior walls of the frontal sinuses, through which the lesion has extended into subcutaneous and intracranial compartments. So now I will ask Dr. Vetrivel to present intraoperative finding, and then we will discuss post-op imaging.
FNA or biopsy from that region?
I'm actually after admission. Yes. The patient is admitted in a ward, and then prophylactically we have started on injection ceftriaxone and vancomycin because of cerebral edema, and the patient is started upon topical steroidal sprays and oral corticosteroids preoperatively, and a neurology and neurosurgery referral has been taken because of the midline shift and uncal herniation. The patient has been started on injection mannitol, dexamethasone, and the tablet levetiracetam has been converted to injectable, and the patient underwent all the investigations like complete blood count, LFT, KFT, chest X-ray, ECG. Everything has been done for PSA fitness obtained, and the patient has been planned for endoscopic sinus surgery with biopsy of the lesion. So he underwent his first surgery on 30th January. Endoscopic sinus surgery has been done with bilateral middle meatal antrostomy, bilateral anterior and posterior ethmoidectomy, and sphenoid sinusotomy and frontal sinusotomy. Intraoperatively, there were extensive polyposis in bilateral nasal cavities with very much inflamed mucosa. So there were very much bleeding. So we concluded the surgery by taking tissue for diagnosis, and the tissue is sent for histopathological examination, CBNAT and KOH MOT. And post-operative period, the patient has been started on antibiotics, and prophylactically antifungals has been started because of the intraoperative findings. In post-operative period, the KOH MOT revealed no fungal elements, and I would now like to invite Dr. Deepali ma'am, Dr. Ratna for discussing the histopathology.
Good morning everyone. Now I am presenting the pathology part of these cases. Good morning everyone. Now I am presenting the pathology part of these cases. Here we received the requisition form with 10 small containers. We received multiple grey white soft tissue pieces from left nasal cavity polyp, left maxilla, left sphenoid, left nasal cavity tissue, left anterior ethmoid, left frontal recess tissue, and left posterior ethmoid, and left nasal cavity tissue, and right nasal cavity tissue. And the all tissues were processed entirely. Here on microscopy, the scanner view showed multiple polypoidal tissue beads. Multiple polypoidal tissue beads lined by respiratory epithelium. And on a low power view and higher magnification showed the respiratory multiple polypoidal tissue bead, respiratory epithelium, inflammatory infected and thickened blood vessel. Here is the respiratory epithelium. Here is edema of the stromal edema. Here is inflammatory cells, and this is the thickened blood vessels. So our final diagnosis was inflammatory nasal polyp, and point of favors of this condition was AIIMS or edematous. Stroma was edematous and mildly fibrotic, covered by respiratory epithelium, and there was presence of mixed inflammatory cells comprising of lymphocyte, plasma cells, neutrophils, and eosinophils. And surface epithelium showed ulceration, and there was thickened blood vessels. And our differential diagnosis was sinonasal papilloma, anterocornal polyp, and allergic nasal polyp. In case of sinonasal papilloma mainly composed of a columnar or squamous epithelial cell and admixed with mucin containing cells, and downward growth of this seromucinous gland gives the appearance of inverted growth pattern. And the stroma shows edematous, granular eosinophilic cells and numerous microcysts, which forms the neutrophilic microabscesses. And in case of anterocornal polyp, surface mucosa will be thin and lack of thickened basement membrane. Stroma appears more fibrotic than edematous, and there will be passive inflammation, fewer glands, and large vascular space or dilated blood vessels. And in case of allergic nasal polyp, there will be prominent eosinophils in the stroma.
So after 10 days of the surgery, the patient has been repeated an imaging in which
The sample number 8, which was fibrotic mass, what was that? Well, they took a biopsy also from the frontal lobe. This posterior ethmoid, multiple gray white soft tissue. So this has nothing to do with the other mass which was there. That is not biopsy. Not this procedure.
We have done multiple biopsies from both sides of the nasal cavity.
Only nasal cavity, not with for that.
Non-frontal sinusotomy we have done, but because of the inflamed mucosa, there were active bleeding. So we concluded the surgery that the tissue diagnosis will be helping in postoperative period.
Actually, that was an attempted, ma'am. It was an attempted frontal sinusotomy. It was an attempted frontal sinusotomy, and that the tissue was so inflamed and as mucosal bleeding was so heavy. Dr. Madhu is here. And, in fact, she was operating. The intent was to clear the disease. We couldn't clear the entire frontal sinus because there was an excessive bleeding and we had to abandon the case in between. Am I right?
Previously operated.
Please, ma'am.
Patient had been
Previously operated.
Why didn't you attack this first rather than the...
Ma'am, our conventional approach, current approach actually to this kind of a problem is that we do a functional endoscopic sinus surgery, and through that we do a frontal sinusotomy and clear the frontal sinus. So we thought we would be able to do it. But this was a revision case actually. There was difficulty, inflammation, lot of bleeding. So the case had to be, without completing that procedure, opening the frontal sinus, exaggerating all the contents, we had to abandon the case in between, satisfying with ourselves with the biopsy, sent for histopathological examination again. Dr. Madhu will clarify she had operated the case.
That biopsy is done in the same procedure. It will be shown just now.
Yes.
Yes. Yes.
Ma'am, posterior table was of the frontal sinus was eroded, and patient had been operated from outside, referred to us, and there was significant swelling in the frontal region. And then we actually the plan was endoscopic sinus surgery, the clearance of all the whatever we could, retaining the landmarks, surgical landmarks. But when we were intraoperatively, we found that the landmarks were not clear. There was quite intraoperative bleeding was much. So, going with the draft 2B was our plan, but we could not proceed further. And then we sent the tissue for biopsy, thinking that we will do it as a staged procedure once we get the report.
And the draft 2 actually is a technical term for an extended frontal opening that we get during the surgery.
Endoscopically.
Yes, endoscopically, which couldn't be done because of the bleeding and the inflammation.
What was the diagnosis after the radiological findings? Because giving an aggressive disease means nothing to us actually. So isn't it possible after radiology that we have some differential diagnosis which were kept before the radiological investigation? Would we tailor to some specific diagnosis, or it was just to worry? I just want to ask from the radiology people that should they give some differential diagnosis? Just giving aggressive disease, would it be sufficient, or something else? It was for
Ma'am, actually, aggressive disease doesn't mean it has to be malignancy only. Even the benign processes which can behave like aggressively, like in this case, we have invasion of the brain and the dura, and there is significant edema. So when we saw the MRI, so two features were pointing towards fungal, because there was diffusion restriction in the peripheral part, and also the lesion was hypointense on T2 in the periphery. And there is a background of surgery and all those things. So, and the edema was much out of proportion to the size of the invasion into the frontal lobe. So personally we felt that it would be primarily an infective or inflammatory pathology rather than being a malignancy, but still since there was invasion, so second duty was to be placed there.
So that is my excellent. I give a differential diagnosis of fungal, then some chronic invasive infection, then malignancy. वो उससे ना हमको थोड़ा सा काफी हेल्प हो जाता है क्लिनिकली. वो आपको बोलना मदर.
I think what I think it is.
Actually, ma'am, what Udit is saying was actually corroborating with the clinical evidence we found in the examination and during the surgery. So disease exactly appeared like how an invasive fungal rhinosinusitis appears, or granulomatous fungal rhinosinusitis appears in the preoperative period, in the peroperative period, and even on radiology, which was done preoperatively. So we had very little doubt that this is not an invasive fungal rhinosinusitis. Only after the histopathological reports were obtained from pathology, then we realized that it may not be actually what we were thinking of. So there is a second stage which is going to come up, which is actually the climax of the discussion today. Yes, sir. So this is not the end of it, and the climax actually is being held by Dr. Prashant. So that's going to open up now.
There was So there was one differential of neoplasm as well in the frontal lobe. What was the possibility, whether it can be a glioma or, but you said no, there was a aggressive tumor. So can it be a glioma?
Dr. Prashant, the findings that they said.
And in neurosurgery people what they said.
So we must see, whenever they write reports, and I'm not speaking on Udit's or Kannad's behalf, whatever findings they write, they always mention at the end of the reports, they must be correlated with the clinical findings. And the kind of polyp the disease was showing in the clinical examination and peroperative period, that was not at all indicative of a neoplastic mass. That clearly indicated it's an inflammatory polyp. So what they write, what they wrote in the reports was we absolutely, we had the same opinion about it. Right?
I'm saying that there was a lesion. there was a lesion in the frontal lobe, big one with some uptake, and can it be a neoplasm glioma? I want to know. Is that the aggressive tumor?
It is not a primary neuro malignancy, sir.
There is a communication from the sinus.
It was not from the brain into the sinus, it was
From the sinus to brain.
So after 10 days, the patient has.
I also put a differential from neurosurgery side as a tissue neuroblastoma that can be extended into major cavity, and it can be but a little possibility, but can be aggressive meningioma. Olfactory group meningioma can be extended in nasal cavity and also in the.
Can we have the radiology again, please?
But it's very little possible.
Actually, we need to see where the extension came from. Yes.
It can go from the later side.
In terms of CT and ignition, is in the frontal wall and the areas of little destruction.
Yes.
Yes, sir. On the sinus CT, there is sclerosis and thickening of the tables of the frontal bone, and there is some destruction along the posterior table and anterior table.
And at the same time, we have to see that there was an inflammatory nasal
Yes,
polyp.
sir.
So we can't overlook that.
So we have two pathologies ongoing which are connected with each other. Post-op.
I will give it. So after first surgery, we repeated the CMRI after 10. Which revealed an residual lesion within the left frontal sinus with decrease in midline shape. This will be discussed later with the post-operative CT. The patient has been taken for a revision surgery with neurosurgery backup. The patient underwent an external frontoethmoidectomy via Lynch-Howard incision. The anterior table of the frontal sinus has been removed with the contents, and intraoperatively there is a defect, dehiscence in the posterior table of the frontal sinus exposing the dura, but there is no active CSF leak and there is no intracranial extension as previously suggested by the preoperative imaging. So there were no intervention from the neurosurgery team. And the tissue has been sent again for KOH mount, activity, CBNAT, and the patient has been continued on antibiotics. In the postoperative period, the KOH mount, this KOH mount revealed a hyaline thin septate hyphae of fungal elements with fungal culture sensitivity positive for Aspergillus flavus. Hence, the patient has been started on tablet voriconazole. Now I would like to invite Dr. Ratna for discussing the histopathology of this surgery.
Again, after 10 days, we received this requisition form with two small containers labeled as left frontal sinus mucosa and left primary and the primary specimen. And for the left frontal sinus mucosa, on microscopy, scanner view and low power view showed the focal and ulcerated respiratory epithelium, and the subepithelium shows the necrosis and inflammatory cells. Here the focal respiratory epithelium and the ulcerated epithelium, and here is the necrosis and the inflammatory cells. And on higher magnification showed the diffuse infiltration by acute and chronic inflammatory cells comprising of mainly lymphocytes and plasma cells and few eosinophils and neutrophils. And for the primary specimen, on scanner view showed the necrosis, giant cell and the necrosis, giant cells and inflammatory cells. And on low power view showing the multinucleated giant cells, inflammatory cells and the necrosis. On high power view showing the epithelial cell granuloma, giant cell and inflammatory cells. Here is the epithelial cell granuloma, here is the Philippi shaped epithelial cells and the rim of lymphocytes, and here is the Langerhans type of giant cell and foreign body type of giant cells. So our final diagnosis was for left frontal sinus mucosa, it was acute necrotizing inflammation, and for primary specimen, it was necrotizing granulomatous lesion. Why it is necrotizing granulomatous inflammation? Because there was epithelial cell granuloma, numerous multinucleated giant cells, inflammatory infiltrate, and background showed focal necrosis. And a special stain done for AFB, pass and fight, and that was negative. So our differential diagnosis was, that time was tuberculosis, fungal infection, sarcoidosis, leprosy, rhinoscleroma, oesogenous granulomatosis, and eosinophilic angiocentric fibrosis. As the stain for AFB, PAS and 5 was negative, so we ruled out the tuberculosis, leprosy and fungal infection. And for the rhinoscleroma, there will be predominance of foamy macrophages and the plasma cells, and there will be also presence of vasculitis, ulceration and pseudoepitheliomatous hyperplasia, and the organism for the rhinoscleroma will be PAS positive. And for sarcoidosis, there will be dense non-necrotizing granuloma which infiltrates into the dermis and extends to the subcutaneous fat. And variable Langhans type of giant cell and scattered lymphocyte will be present, and there will be also be present of fibrinoid necrosis, Schumann bodies and asteroid bodies. And for oesogenous granulomatosis, there will be leucoclastocytic vasculitis with geographical necrosis, and there will be lymphocyte poor granulomatous reaction, and epithelial ulceration, fibrinoid necrosis and eosinophil also present in oesogenous granulomatosis. And in case of eosinophilic angiocentric fibrosis, there will be perivascular fibrosis, which is called onion skin fibrosis, and there will be mixed inflammatory cells, which will be rich in eosinophils. So the granulomatous inflammation is a form of chronic inflammation characterized by collection of activated macrophages with T lymphocytes often associated with necrosis. So granuloma.
So with this histopathology of necrotizing granulomatous disease with necrosis features, we worked up for granulomatous diseases of the nose. So the tissue has been sent for AFB and CBNAT, which is negative for acid-fast bacilli, and Mycobacterium tuberculosis was not detected. And for syphilis, we done RPR, and the non-specific markers, the C-reactive protein and erythrocyte sedimentation rate were raised in the individual. But the other markers of granulomatous disease, such as serum ACE and cytoplasmic antineutrophilic cytoplasmic antibodies, were negative for the patient. So with this panel of workup, we didn't conclude a specific granulomatous disease. In an Indian scenario, with necrotizing granulomatous pathology in histopathology report, so we probably think of tuberculosis, and the patient has been started on category 1 antitubercular therapy, and the patient has been attached with DOTS therapy. And the patient has also started on the antifungal therapy because of the fungal culture being positive for aspergillus flavus. But the final histopathological report doesn't reveal any invasive nature or any fungal stain was negative in the biopsy. And the patient has been discharged on the postoperative day 11 with continuing ATT and antifungals. And I would now like to invite Dr. Kanak to discuss the postoperative radiology.
Some other meeting, only question which is baffling me is what is the cause of the shift, the brain shift and edema, and also maybe if we shift missed anything, I have to attend another session.
Okay. Thank you.
This is the post-phase MRI before the frontal sinusotomy. As you can see, the maxillary sinuses and ethmoidal sinuses have been debugged and cleared. Mucosal thickening is reduced. But the frontal lesion was not addressed at the time of the scan, and mass effect and edema and the lesion remain the same as in the pre-op MRI. it's the same. And there is one post-op CT which was done after frontal sinusotomy. There is pre or post-op changes in the skin and frontal sinuses. Some hemorrhage is there and some part of the lesion has been removed. The blood attenuation contents are there in the surgical pad. This is the osteotomy site and post-op changes. And mass effect is reduced to some extent. So was the lesion removed in toto entirely? Yes. So any questions for radiology?
So the patient after 2 months, there was no swelling. The swelling in this supraorbital region is significantly reduced and proptosis has been decreased. So the final diagnosis will be the granulomatous disease of nose. This is the classification of granulomatous disease of nose. It might be due to infective etiology, inflammatory etiology, or neoplastic etiology. In infective, we have bacterial, which includes tuberculosis, lepromatic, and rhinoscleromas. And in fungal rhinosinusitis, we have aspergillus, rhinosporidiosis, and protozoal, we have leishmaniasis. Inflammatory diseases like sarcoidosis and venous granulomatosis, which is now called as granulomatous with polyangiitis. So the clinical picture was previously entirely of chronic rhinosinusitis, but the postoperative tissue diagnosis comes to be a granulomatous disease, which is a contradicting diagnosis. The granulomatous disease usually presents with a nasal crusting and with history of bleeding and all, which is not present in our case. So,
Dr. Vetri, please come on to the previous slide. Now here I'd like to point out
that points in favor of chronic rhinosinusitis, all of those points may be present in the granulomatous disease also.
Yes.
And the points which you have written against the granulomatous disease, they are actually not always present. We must remember this. So crusting is no criteria. And the patients who are having granulomatous disease, very often these patients are reportedly immunocompromised patients. So immunocompromise is also not a point against granulomatous disease. So most of the points till now, they were actually favoring the granulomatous disease.
So as described, it is equally favoring. Coming to the relevant guidelines, we followed European position paper of rhinosinusitis guidelines, and the patient was started on oral and intranasal steroids, and the patient has been taken for surgery because medical management didn't cause improvement in the patient. I would like to discuss few relevant studies. So this was a case report of an atypical Potts-Puffy tumor which presented with a temporofrontal swelling. In this, the FNAC revealed tuberculosis and ATT has been started. In this, the subcutaneous plane of the temporofrontal region is in communication with the intracranial part, but there was no cerebral edema in this case. And Galvez et al. Proposed a staging of the Potts-Puffy tumors based on the clinical and MRI findings. So they classified the Potts-Puffy tumor into 3 grades, with grade 1 showing no intracranial involvement and that there is a mild cellulitis in the frontal region. And grade 2, there is formation of abscess in the frontal region with dehiscence of the anterior table of the frontal sinus. And in grade 3, there is intracranial involvement with breach in the posterior tibia. So the treatment will be medical for grade 1 and surgical evacuation of the contents in grade 2, and grade 3 neurosurgical and ENT team. There will be combined approach for intervention.
So we're going to stop here and have further comments from
So questions are welcome from the audience.